Hello again, and welcome to Chapter 22, Assessment of the Respiratory System. Chapter 22 focuses on the assessment of the respiratory system, and concepts for this chapter are gas exchange and perfusion. Now again, we covered concepts of this being gas exchange and perfusion, but the respiratory system creates gas exchange by O2 transportation to the cells and CO2 transportation away from the cells through ventilation and diffusion. Now, if you're asking yourself what ventilation and diffusion are, ventilation is air movement or oxygen from the atmosphere into the lungs and CO2 removal. Respiratory diffusion is movement of gases down across the alveolar and capillary beds. How the oxygen gets into the tissues from the lungs. Perfusion can be divided into two categories. There's peripheral, which is the arterial blood flow through the tissues, and then central perfusion, which is that arterial blood flow pumped by the heart. All systems depend on adequate gas exchange for tissue perfusion. So for a review of the anatomy and physiology of this, we talk about the upper airway, the lungs, the lower airway, the alveolar air sacs, and the gas exchange. Then we talk about perfusion. That upper airway consists of the nose, the sinuses, the pharynx, and the larynx. The lower respiratory tract consists of the airway, the lungs, and those accessory muscles. So this is a picture of the upper airway. You can see that it's consisting of the nose, the sinuses, the pharynx, and the larynx, and it's just a good A&P review to kind of showcase how things are coming through the body into the lungs in order to get that perfusion going. As a continuation of that, this is the lower airway. We're looking right at the trachea or the windpipe, as some others will call it, going down into the lungs, how those lungs are divided into your lobes, how those lungs are divided into the bronchi, down to the alveolar ducts and the alveoli, all the way down to our diaphragm, which is that muscle that helps us breathe. So when you read your chapter, you might have been thinking, are respiratory changes associated with aging? Are there things that are natural to be changing when our body is aging? The answer from most textbooks will tell you that there is no change in respiratory that occurs naturally. So we shouldn't be seeing people have a decrease in their ability to breathe unless it's from a disease process. So the only exception to that can be hereditary. So you see patients who are born with things such as cystic fibrosis or who develop emphysema over time. These are typically related to a genetic component, but when we look at things like lifetime exposure, those are what can cause those changes during aging. So that can be environmental pollutants, that can be chemical plants, smoking inhalation, and precipitate inhalation. So when we talk about health promotion and maintenance, you're going to find that I stress a lot of time on this, and it's because I feel like as nurses, we have such a great ability to make a difference in people's lives. We're there day to day taking care of them, and we have this ability to kind of not only educate them, but help them make different life choices that can positively impact their health. So the biggest thing when we talk about health promotion is to minimize exposure to inhalation irritants. Now, you're going to hear me stress a lot about smoking cessation during this part of the PowerPoint. And again, unfortunately, it's not a popular topic, especially for those who smoke, but a very important topic to assist with patients with lung disease. This is one of those preventable lung issues. So there are many types of inhalation smoking issues. I'm just going to cover three. Tobacco is the most common of the inhaled through cigarettes, pipes, hookahs, or vaping. 13% of the population in the United States and Canada smoke cigarettes. This has declined from past years, but tobacco usage can be measured by pack per year. This is done by taking the number of packs smoked per day times the number of years smoked. The next thing we talk about is marijuana. This is also inhaled in through the lungs, and it's Legal per different states, but not federally. So still not okay for federal funded facilities. This can also cause a lot of issues with your mental health as well, being that it can cause some hallucinations. Now, when we talk about marijuana usage, you will get patients in the hospital who will tell you, well, it's legal, so it's okay for me to smoke. Yes, per state, it is legal, but unfortunately not per federally funded, and the majority of hospitals are federally funded. The newest addition to smoking issues is vaping. Vaping can lead to popcorn lung and lesions caused by what's called EVALI or EVALI, and that stands for e-cigarette or vaping products used associated lung injuries. This is the first identified in 2019, and it's something we're still learning about. I mean, if you think about cigarette smoke, they used to smoke within the hospitals, and now we've learned that that can cause a lot of injury to your lungs, and there's a lot of problems associated with it. I think the same thing's going to happen for vaping. We are noting that it can lead to popcorn lung and lesions within the lungs. I think we're going to find out there's far more damage going on with those chemicals that are being inhaled over the next few years. So, smoking is a modifiable factor that increases the risk for cardiovascular disease, stroke, and many types of cancer. Let's dwell on that for a moment. So not only does it affect our lungs, but it also affects our cardiovascular system, can cause strokes, and many types of cancer. Do you remember me telling you that this is a modifiable issue? This is why I stress that health promotion. So there are three components in cigarette smoke that have been implicated in the development of serious lung disease, and they are tar, nicotine, and carbon monoxide. The goal of health promotion is to promote smoking cessation. So when we talk about promoting smoking cessation, there are cessation protocols. We start with the 5 A's of smoking cessation. So that stands for ask. We want to identify and document tobacco use status for every patient at every visit. We want to advise. In a clear, strong, and personalized manner, we want to urge every tobacco user to quit. We want to assess. We want to determine the tobacco user's willingness to make a quit attempt at this time. We want to assist. For those willing to quit, we want to provide counseling and pharmacotherapy to help them succeed. And we want to arrange, schedule follow-up appointments to support that quit attempt and monitor progress. Remember, this is a teaching moment for smoking cessation. There are many types of drug therapies that we can utilize for smoking cessation. There's over-the-counter nicotine replacement, and it's important to stress the fact that whilst taking nicotine replacement therapy, like a nicotine patch or the gum, smoking will increase the risk of stroke or heart attack in that person if they are still smoking while on the patch or utilizing the gum. And that's because, again, we're causing all of those different blood vessels in the body to constrict, so we're limiting blood flow. And if we have two types of nicotine coming in at the same time, we are further limiting that blood flow. Then there's bupropion. There is a black box warning on this medication, though, regarding an increased suicidal thoughts and behaviors. So it works by decreasing cravings and withdrawal symptoms. It also can help with reducing depression. Then there is varenicline. It interferes with the nicotine receptors. This promotes smoking cessation by reducing the pleasure and symptoms of nicotine. So I talked a lot about smoking cessation, but it is not the only type of particulate matter exposure that our patients may come in contact with. Common causes of chronic lung disease are completely correlated with our particulate matter exposure, and they can also exacerbate acute problems. So things that we're going to look at use the mnemonic I prepare, and that is the model on box 22.3, and that stands for investigate potential exposure, present work, where do they work, what is causing these things, where they reside, what environmental concerns are in their area, where have they worked in the past, what activities do they partake in, are there any referrals or resources this patient needs, and then how can I properly educate them. So we're going to talk a little bit more in more slides about how this kind of relates to our patient, but the I Prepare model is just a really great way to kind of get that conversation going. So once we get through our introduction phase of meeting a new patient, we're going to talk a little bit more about recognizing those cues and doing a really, really good, solid assessment. One of the biggest things that can affect our patient is knowing what their history looks like. So Do they have a respiratory history? Do they already have a pre-existing condition such as emphysema? Do they have a genetic component like a cystic fibrosis? Have they had infections in the past or injuries to their lungs or respiratory tract? Are they a smoker? Do we need to calculate a pack per year? So an example of this would be someone who smokes 1.5 packs per day for 20 years. They have a 30 pack per year history. So that patient is going to have much more lung damage than your patient who just started smoking. We talk about drug use, prescribed and illicit. Both prescribed and illicit can affect lung function when taken systemically. We'll talk about complementary and integrative therapies, so they can cause permanent changes to the lungs. So, for example, a patient may have pulmonary fibrosis, and if they're receiving medications like bleomycin, that's a chemotherapy agent for cancer, or amiodarone for cardiac problems, those can cause long-lasting effects on their systems. We also talk about marijuana and cocaine and how those can reduce lung function. We talk about allergies, so if they have any food allergies, dust, mold, pollen, trees, grass, drugs, animal dander, or saliva, and bee stings, which can all affect that breathing. Think about a patient who is allergic to bees. They get stung by a bee, that airway swells right up, and they lose the ability to breathe sometimes. So knowing that that is a problem with our patient can help us care for them much, much better. Travel in geologic area of residence. We talk a lot about how a patient going to other places that they may not be as familiar with may contract things that they are not normally exposed to. One thought about this is like histoplasmosis, which is a fungal disease from contaminated dust that can be found in central parts of the US and Canada. We talk about coccidioidomycosis, which can be found in Mexico and southern states. Hantavirus, which can be found in Central America. We could also talk about the fact that veterans should be asked about when and where they're deployed to different areas. An example, Agent Orange in Vietnam veterans is still a problem for some of our patients. Family history and genetic risks. So again, that cystic fibrosis or emphysema that have those genetic correlations. People with asthma also have a family history of allergens. So your mom might have just been allergic to ragweed, and unfortunately, you were the lucky one to develop asthma. Patients with tuberculosis often are from the similar environment of their family, so that leads them to have that higher risk as well. Current health problems. So if we see a patient who has cough, increased sputum production, hemoptysis, which is that blood in the sputum, dyspnea, which is that shortness of breath, orthopnea, which is shortness of breath that occurs when lying down. Those are all things that we're going to further kind of assess to see how we can have our patient be at their highest potential. So part 2 of this assessment would be recognizing those cues. This would be that physical assessment. So when we're assessing, we should ask ourselves, what are we hearing? Recognizing what you're picking up as you're assessing your patient, as you talk to them. You want to take an excellent history. In terms of respiratory, we often ask about any smoking in the home. Depending on this, maybe how you are going to develop that care. This becomes an opportunity to talk about those risks. So this is a picture of the sinuses and where those are located. I put this on the slides just because I feel like this kind of helps you identify where you look for any of that pain, or some patients might come in and say, gosh, my cheeks, they really hurt, or I keep getting these headaches just in like the front of my forehead. And that can be related to like a chronic sinusitis or inflammation in those areas. So it kind of like helps us cue into the fact that that could be what that is, and not an actual like musculoskeletal injury. So this is a picture of the structures of the pharynx, the trachea, and the larynx. When we look about this, one of the biggest things you're looking at is going through those vocal cords. So when we talk about those patients who are intubated for a procedure or emergently because they're having issues breathing, this is going through that glottis that they're talking about. So I just kind of wanted to give you like a cutaway view of what that looks like. So again, in regards to our assessment, it's really imperative that we know where to assess our patient as far as their lungs and their thorax. This image offers a view of the sequence of percussion and auscultation. So it's good when we're trying to think about how to listen to those lung sounds, how to auscultate, and where to percuss in the proper order. Continuing on with that physical assessment, we're also going to talk about the different things that can show us indicators, skin and mucous membrane changes, and the general appearance and endurance. So when we're inspecting our patient, we're looking for those normal landmarks of the chest front, which is the anterior, and back, which is posterior. We're going to work from the top, or the apex, downward towards the base, going side to side. We're always comparing sides because, again, we're trying to develop what is normal for my patient so that at my next assessment, I can determine whether or not we're making progress in the right direction. We want to look for discoloration, scars, lesions, masses, and spinal curvatures. We want to compare each side to the other. We want to observe that rhythm, rate, and depth. We want to note any crepitus, or air trapped in and under the skin, and phremitis, which is that vibration felt as a patient speaks. As phremitis is decreased, it's showcasing us that a lung space may be obstructed. When we talk about endurance, we're talking about how that patient is able to handle any other increased respiratory demands. So a great way to assess this is having your patient walk around the room with the pulse ox on. So when we're having them walk around the room, this could be with or without supplemental oxygen. If the patient does not normally wear oxygen, but had to have a procedure done and now the procedure is completed, with the proper orders from the provider, it's important to attempt titrating down and discontinuing that oxygen therapy as we're able to. Does your patient have the ability to get up and walk across the room without respiratory decompensation? We assess this by putting on that pulse oximeter on the patient and assessing them before we walk, during the walk, and after the activity. This will alert us to what is the next course of action in regards to oxygen therapy with this patient. Another portion to our assessment is the psychosocial. We're talking about anxiety. This can impact a person's breathing pattern. This can increase respirations, but an impairment of the respiratory tract can also increase anxiety. One might say that these two issues can cause the other issue to occur. Has the patient had any role or relationship changes? Did our patient used to take care of their loved one and now related to work of breathing, are they requiring being cared for? Social isolation. As our patients start aging, they start losing family, and that can be very sad. Did they used to live with their spouse, but now they're widowed? Have they been unable to work related to a disease process and so now are unable to pay their bills? Did their job cause respiratory issues related to environmental exposures such as dust or pollutants and now they're unable to hold a job? Has your patient been declared disabled and not able to work? The more we can tie all these things into the disease process, the more we can see these diagnoses come together and better help our patient. A type of cue we can assess in laboratory and diagnostic testing would be the red blood cell counts, our arterial blood gases, which we learned about in the last chapter. Sputum specimens are a good place to start and the least invasive. The next line of assessment would be the imaging through a chest x-ray or a CT, which is a computed tomography, with or without contrast. This kind of lets us see how the lungs are handling breath coming in and out and if there's any vascular issues. And the next and still non-invasive thing is like a pulmonary function test, an exercise test, or a capnography. Now keep in mind these are non-invasive tests, but they're also a little more stressful on your patient because they require them to do activities that take them past their normal baseline. Now we're moving into the last part of our assessment, which is those invasive diagnostic assessments. We can do these through endoscopic examination. These would be like a bronchoscopy, thoracentesis, or a lung biopsy. A bronchoscopy is insertion of a tube, or that endoscopic exam, into the airway. It goes as far as the secondary bronchi to view airways and to kind of visualize those airway structures, but also attain tissue samples. It's utilized to diagnose and manage pulmonary diseases. Patient preparation will include monitoring those labs, making sure that our patient doesn't have any issues with our hemoglobin in case there is a potential for bleeding. We do a chest x-ray to make sure we have the anatomy correct before we go down. And this patient is NPO for 4 to 8 hours prior to procedure to reduce the risk of aspiration through vomiting. We could pre-medicate these patients with sedation, opioids, or amnesia, but usually they're just monitored for patient comfort. This can occur in an ICU bed at the bedside or in a bronch suite. They normally spray the oropharynx with lidocaine, so it's important that we maintain IV access. We are doing continuous vitals, and we are utilizing supplemental oxygen as our patient needs. One of the biggest things for nurses post-procedure is assessing that gag reflex and lung sounds. These will need to be assessed every 15 minutes for the first 2 hours because of potential complications such as bleeding, infection, hypoxemia, and aspiration. So if my patient just gets back and they're complaining that their throat is sore and they'd really love a drink of water, the first thing I'm going to do is I'm going to assess their gag reflex. And if it is not there, they are not getting a drink because I do not want them taking that water into their lung. The next test would be the thoracentesis. This can be done through needle aspiration of pleural fluid or air from the pleural space for diagnostic or management purposes. So we talk about a lot of these being diagnostic, but if you have fluid in the lung and it's impairing their ability to breathe, we can actually manage that by putting in a tube to drain the fluid and allow them to have that clear airspace. For prep and monitoring, we're going to, very similar to the bronch, we're going to do that chest x-ray before, but also post-thoracentesis because we're looking for that mediastinal shift. Did we accidentally cause that lung to collapse, which is pulling everything to one side? This can also put our patient at risk for that subcutaneous emphysema or that air trapped under the skin because we are entering from our atmosphere into the lung. Pneumothorax can be a partial or complete collapse of the lung. The last thing we talk about on this slide is a lung biopsy, and this can be completed via transbronchial biopsy. We can do this percutaneously, we can do transthoracic or an open lung. Depending on how we do this is depending on our post-op things. An open lung tends to be quite a bit more invasive, so those patients do have a lot more issues that can develop. It can be used to make a definitive diagnosis of inflammation, cancer, infection, or lung disease. But again, our lung biopsy is not what we jump to. We start with those non-invasive tests. This would be if we're trying to confirm what something is suspecting. So, assessment of a patient receiving oxygen therapy. Think about who would need oxygen, why they would need the oxygen, and most certainly how long they might need it. Asking yourself how long they may need it is helpful because it may only be during a certain period, like after sedation, they just had anesthesia or pain medication. This may be somebody that's in their early stages of COPD or someone with an exacerbation of asthma. Maybe we can get them off oxygen therapy, or maybe this is the start of a continuous treatment. It's important to think about why we are giving oxygen because then you have the ability to properly titrate off or trial them on room air. The purpose of oxygen therapy is to relieve hypoxemia and hypoxia. So hypoxemia is those low levels of oxygen, and hypoxia is a decreased tissue oxygenation. Our goal is to use the lowest fraction of inspired oxygen for acceptable blood oxygen level without causing harmful side effects. When we Talk about oxygen delivery systems. This depends on the required oxygen concentration. Oxygen concentration that can be achieved by a minimal delivery system is always our goal. It's important that we're making sure we're being accurate and we're controlling that oxygen concentration. We're going to look to our patient for cues. Is our patient comfortable? Are they complaining that their nose is super dry, and are they having nosebleeds? Because that could be indicative that the air that we're blowing into their nose is drying that capillary bed within the nasal pharynx, causing irritation, causing bleeding. We can fix that with humidity. We're going to assess our patient's mobility. I don't ever want to make my patient have to be strapped to a bed if they do not need to be. So if I just have to put in a couple liters of oxygen because as they were walking, they were dropping, I'm going to make sure that I can make that portable for them, that they still have the ability to be mobile. And I'm going to educate them on how we can do those things. So when we talk about low flow oxygen delivery systems, these are the most easy to use, the most comfortable. This would be like that nasal cannula, which we can utilize from 1 to 6 liters of oxygen, or that face mask, which is like a partial rebreather or a non-rebreather. When we're receiving oxygen therapy, this can help decrease problems like impaired gas exchange. The normal atmosphere of oxygen that you and I are breathing in without oxygen right now is 21% oxygen. Something that's kind of a fun fact is with every liter of oxygen we're giving our patient, we're increasing that oxygen percentage by 4%. So if I'm giving my patient 1 liter, they are now up to 24% of oxygen delivery. So for nasal cannula, the flow rates, like I said, are from 1 to 6 liters. You will see people go in and just crank that all the way up to the 15 liters on the wall mount. I will tell you that that is not effective. Your patient's not able to get greater than 6 liters because the gas exchange from the anatomical dead space is full. O2 concentration of 24 to 44%, 1 to 6 liters per minute. Often used for chronic lung disease or long-term therapy. You also see your patients coming back from surgery with a nasal cannula or a non-rebreather in just to kind of assist them through that period where they're not breathing as well as they normally would. Some people do not tolerate the nasal cannula. They do not like those little prongs up inside their nose. Something we can utilize to help those patients is a simple face mask. Now, this may seem counterintuitive. They're not tolerating something in their nose. How would they tolerate something on their full face? It ends up being that feeling of claustrophobia. And vice versa. Some people prefer a nasal cannula over a simple mask. Now, with a simple mask, I can increase that oxygen delivery to 40% to 60% for short-term therapy. But these have to be a minimum of 5 liters. This is where we're using that mask to go up even higher. We also want to make sure we're ensuring a proper fit, and we're using that little metal prong on the top of the mask to assess that that's squunched down on their nose well, but not too tight. We get it too tight, we're starting to obstruct that airway. So we have someone heading towards an emergency. We may put them on a partial rebreather mask. This provides 60 to 75% of the flow rate at a 6 to 11 liter per minute. These patients will breathe 1/3 of the exhaled tidal volume, so that can help our patients who are blowing off too much CO2. So the non-rebreather mask is that delivery of the highest O2 level on the low flow system. It can deliver up to a 90% oxygen to our patient. This is used for unstable patients who may be requiring intubation. It's important that we ensure the valves on the bag of this mask are patent and fully functional. We also want to make sure that that bag underneath the partial rebreather mask and the non-rebreather mask is inflated, because that lets us know that that mask is functioning properly so that we can have that proper CO2 oxygen exchange. To our high flow oxygen delivery systems, we look at our high flow nasal cannula or our Venturi mask. These masks can give more pressure to our patient to assist with their breathing. My first experience with a high flow nasal cannula was during COVID with our patients who were really struggling with that lung problems. It can be a little terrifying at first, especially when patients feel like they can't breathe. That anxiety really gets in the way of things. But again, it's one of those things where being empathetic and really trying to help our patients through these processes is super important. So High flow nasal cannula has the ability of 30 liters per minute to 60 liters per minute. We use a combination of heat and humidity to minimize damage to that mucosal membrane because, again, we're blowing air at such a rate that you can just cause so much trauma to that nasal passage. So this is a picture of a Venturi mask. The cool thing about a Venturi mask is it's got an adapter located at the bottom of the mask and it connects to the O2 source even below that. This pulls a proportional amount of room air for each liter of oxygen it flows. So we have that mixing of the atmospheric air with the 100% oxygen to allow our patient to have a better chance of kind of utilizing that air in a way that they can make that gas exchange within their lungs. Now we're going to talk about the non-invasive positive pressure ventilations, or the NPPV. These use positive pressure to kind of help force those alveoli open, and they can improve gas exchange. So this would be for your patients with COPD. Ways you might see these would be a CPAP, a BiPAP, volume limited, or flow limited devices. They may bring these devices from home, and there are many different types of devices. I always like to think my patient is the expert when I'm taking care of them. These patients who are prescribed the CPAP, the BiPAP, they are taught how to use this machine. They have gone through the testing to make sure that these devices work for them. You'll also see these with your patients who have sleep apnea. That airway, while they're sleeping, for some reason is closing. They'll give them this device just to help them get through it. So this helps force that airway open. These patients get better sleep. However, some CPAP BiPAP machines can be very cumbersome, so finding the mask that fits your patient is super important. Now, most hospitals will have CPAPs and BiPAPs available for your patient who comes into the hospital. Some of your outlier hospitals or community hospitals may rely on that patient having family bring that in. Let's talk about the hazards and complications of oxygen therapy. When we talk about combustion, yes, that does mean fire. So one of the scariest things or patients I've ever taken care of is the patient who is on home oxygen continuous therapy, who is still a smoker and decides that they don't want to get short of breath while they're having a cigarette, so they're going to smoke with the oxygen on. It explodes. It blows up literally in their face. These patients come in very embarrassed, if not horribly injured. They usually end up in the ICU, and they come in with facial burns to their wherever the oxygen tank was. Also, we worry about that inhaled burn. So these patients could potentially need to be intubated because as they were inhaling that smoke and oxygen, they were actually burning all of their upper airway. So these patients are quite precarious to take care of at first. When we talk about oxygen therapy, we also talk about that toxicity. So if I have a patient who's on oxygen therapy and a COPD patient who retains that CO2, if I give them too much oxygen, I actually decrease their drive to breathe. And so we can actually worsen their disease process. So continuous levels of greater than 50% oxygen for more than 24 to 48 hours can also cause lung and tissue integrity issues. When we talk about absorption atelectasis, this is that crackles that are heard when that alveoli has been pushed so much that it's actually collapsed. We talked a little bit about drying of the mucous membranes. Again, whenever I see that or I have a patient who's complaining that now they have nosebleeds, first thing I want to do is start applying that humidity. We talk about infections, so it's very important, especially for those patients bringing in that device from home, that we're making sure that they know how to clean and change that equipment. Those tubings need to be changed and wiped out. In the hospital setting, the equipment is changed out depending on the facility. So some facilities do it as frequently as every 12 hours. Other people do it every 7 days. So knowing the facility's procedure on this is pretty important. Just like in past chapters, I have left up your questions that we're going to review in class, so please feel free to go through those and we will cover them in class. Thanks for listening.